if you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
Yeah, we can definitely do that, or we could be better clinicians and use our ultrasound.
Okay, let's do this. The gallbladder. I had a student who came out from Germany a few years ago. She was, I would say she's pretty serious. She's a pretty serious person. She was in our QA session. We're doing tape review, ultrasounds and everything. And I asked her, how do you say gallbladder in German? And she said, Gallenblase. And I said, oh, Gallenblasen? She goes, no, Gallenblase. And I said, Gallenblasen. She goes, not blasen, blaza. I'm like, what's the difference? She's like, you can't say blasen. It means and there it is, right there in Urban Dictionary. She wasn't kidding. So, so don't say Gallenblasen. That's super confusing, particularly if you're out late night in Germany.
No. Your ears aren't playing tricks on you. You're listening to the wondrous sounds of the educational, often inappropriate, always entertaining Chris Fox. Chris made it back to Castlefest this past year and blew our minds with gallbladder ultrasound, appendicitis ultrasound, DVT ultrasound. So I wanted to give you a taste of what listening to Chris speak live is all about. And I felt like gallbladder is the thing that we've probably discussed the least recently on the podcast. So listen up and learn yourself a thing or two about the gallbag and maybe a little German along the way. Take it away, Chris.
So, the way you do the Gallenblase ultrasound is I like to start with the big curvilinear transducer. Whenever I can get away with using that big, fat, curvilinear probe, I think of all the probes, that thing always gives me the sickest image. So I will try to get away with that whenever I can, and this is a wonderful place to start here. Even if you have a patient who's really big, hey, if they're doughy, you can push in on them, and as they take a deep breath, you'll be able to see their gallbladder. I start in a sagittal plane, and I slide the probe laterally along underneath that costal margin, as you can see there, as the patient takes a deep breath. As they take a deep breath, the diaphragm comes down, and the liver with its gallbladder dangling off of it come out of that fossa there, and you can see it on ultrasound. And I roll the patient on their left side. It gets kind of some of those loops of bile to slide out of the way. When they roll off on their left like that, you can imagine that second portion of the duodenum that runs right up against the posterior wall of the gallbladder starts to kind of slide out of the way, and it kind of gives you a good image. In fact, you can see the duodenum here with its air in it right along that posterior wall of the gallbladder. That's a gallstone with a shadow. That's air in the duodenum. And that's really the ultimate conundrum when you're doing biliary ultrasound, is trying to differentiate, wait a minute, is that air inside the duodenum or is that a stone inside the gallbladder? So that's kind of how I think of it. And again, in that transverse plane, you can have the patient take a deep breath, you roll them over on their side, gets that duodenum to slide out of the way, and this is really how I get the image here. I roll them on their side. I'm still trying to get away here with using that large footprint transducer whenever I can. Now, if I can't get that large footprint transducer, I'll switch it up to a smaller footprint. You could use your phased array probe. Some people have a microconvex transducer that works really well between the ribs, and we call it the X-7 approach, the X being the xiphoid process. You're going to go to the right here, 7 centimeters or so. Sometimes it's X-10 or 12, depends how big your patient is, but you get the idea. You're between the ribs. And in some patients, this is the only way you're going to see their gallbladder. It just depends how if they have more of a rounded gallbladder higher up in the abdomen, this may be the location that you score it in. Gallstones are really nice because they shadow. Gallstones cast a shadow, and that's what makes them so wonderfully sonogenic, sono-friendly, because they have this nice, there's a whole bunch of stones here at this coming together to make this beautiful shadow coming down here. And as you move the patient around, the stones, them too, will move as you move the patient. You sit the patient up, you'll see the stones travel. Watch this one here. This one's down the neck. Now I'm gonna take this patient, lean him forward, and it's like it's crawling up to the fundus. How cool is that? So it's like stupid pet tricks. You can have the patient lean forward, and then you can watch this little gallstone meander like it's got feet and goes right up there to the fundus. And I could watch this video all day long. And that's what makes ultrasound so sensitive and specific. It's actually better than CT scan for gallstones. How many times have you seen that? You don't see, like, wait, I saw gallstones in that patient, and then it's not in the CT report. It's kind of interesting. So this is one of the areas where ultrasound beats up on CT scan. So that's another reason why I like it so much. Now, the problem, though, is this whole spectrum with the chylomicrons, right? They're like crashing out of solution, and their tails are lining up, and then, I'm just making this up, actually, and then they sort of get more, like, viscous, and they start crashing out of solution, and they get sludgy, and then that sludge starts to coalesce, and you get stones. But before the stones, you get the sludge usually, and so that's what we're looking at here. Sometimes it's even hard to see the gallbladder when it's filled with sludge. Here's the stone down here in the neck. That's the stone in the neck of the gallbladder with the sludge around it there. Luckily, we were able to see that one. This is the same patient, little technique here. Same patient. What do we do differently in that image on the right? Because we want to see these gallstone shadow, right? What did we do to the machine? We clicked a button. What did we do over there? Any ideas? We wanted the sound. If you look here, the sound got attenuated more. It didn't go past the gallbladder. So if we want that sound to attenuate more, we could turn up the frequency, go to the resolution mode on some of the machines. That's what they call it. Or just hit your frequency button, bump it up a little bit, and you're like, oh, okay, no, that's totally a stone. It's shadowing now. So that's one thing you can do, a little trick there to get that shadow to come out. Here's another little problem with the gallbladder. It's if it's contracted. When the gallbladder contracts down on a stone, when you have a good ejection fraction of your gallbladder, squirts out that bile, and then it contracts down around a stone, what can happen is that you can't find the gallbladder anymore. You're just like searching around the abdomen, and this is like all you see. This is the image that you see. Now, this is a still image, not a video. If the video was playing, you'd be able to see maybe this is like a loop of bowel over here peristalsing, but this is definitely not peristalsing here, and that's going to make you wonder, I wonder if I'm looking at a West sign or wall echo shadow. It's the anterior wall of the gallbladder with the echogenic stone, and then the S stands for the shadow that comes down behind it, the West sign. It's a contracted gallbladder on a gallstone. So begin to wonder about that. Again, the conundrum. What are we looking at on these images over here? This looks a lot like a contracted gallbladder, doesn't it, with sludge in it? Maybe over here we see a contracted gallbladder with stone and some shadowing. What do you think? It's the gallbladder. It's the duodenum, not the gallbladder. So that's the whole problem here, is that duodenum can really look like the gallbladder sometimes. And as it's contracting, what you'll see is live peristalsis here when it's contracting. And then here's the other dead giveaway, is that the outer wall of all of the loop of bowels in our body, from our esophagus all the way down to our rectum, they all has this hypoechoic surrounding around the outside of it there. That's how I know that that's a loop of bowel. So it peristalsis and it's hypoechoic there. But I mean, like at this one here, this is from our old ultrasound machine, 2000. This is probably circa 2002, a BK Hawk ultrasound machine. We actually still have it. It still works. We don't really use it though. But you can see they're saying, is this a West? Is this a West? What do you guys think? Is that a West sign? Nope, it's the duodenum. It's got a hypoechoic outer wall to it, and if you watch it for a while, it'll peristalse on you, and maybe you'll see some of these comet tails moving around on you there. And stones won't do that, right? Stones will cast a very anechoic shadow, not this bright comet taily thing. That's how we know that's another reason we know that that's the duodenum. Good. How about this one? We see this is a very contracted gallbladder here, all the way down around a whole string of stones. Resident says, I can't find the gallbladder. I don't know what's going on. I walk in the room and roll the patient on their side and see that. How about this one here? Liver. Here's the wall of the gallbladder out here, and there's just a little bit of sludge down here. That sludge, it like layers out like a meniscus, okay? It's very isoechoic, okay, and layers out like that. You don't see a bunch of undulating, you don't see like an undulating pattern to it. If I saw an undulating pattern with alternating levels of echogenicity, what might I be worried about? It's something I think about every time I see sludge. I just try to check myself for a minute and go, shit, I hope this isn't, what? Cholangiocarcinoma, right? And so that's the one thing. It's rare, but hey, it's kind of like every time I go listen to somebody's back with my stethoscope at somebody who has asthma, I might also look at their skin for maybe, like a melanoma. If I'm looking at somebody's gallbladder for gallstones and I see sludge there, I'm wondering to myself, is this cholangiocarcinoma? I have no idea why I just made that analogy, but it seemed to come to me in the moment. We're going to put this anterior wall gallbladder measurement here, right along that anterior wall. That's where you want to measure the gallbladder wall to see, anywhere along here would be fine to measure the thickness. Up to 3 millimeters is normal. Definitely more than 5 millimeters would be considered abnormally thick gallbladder wall. A bunch of things can cause the gallbladder wall to become thick. Cholecystitis, probably the most common, but you can also have something called adenomyomatosis. You can also have ascites, right? All of our alcoholic liver disease patients all have super thick gallbladder walls. It's really hard to tease out which ones, have acute cholecystitis from it's just ascites there. But in just straight up cholecystitis, more than 5 millimeters of distance is certainly concerning. And depending on their insurance, between 3 and 5 millimeters would be normal or abnormal. So I have my surgeons come down 3.5 millimeters. Yeah, we're going to take it. We think it's acute cholecystitis. We'll take them. Oh, look at that, PPO. Oh, another patient comes in self-pay. Well, it's not 5 millimeters yet, so I think we can sit on this one a little with some antibiotics. We see that a lot. Contracted gallbladder. This is this thing I remember when did the patient eat? Because we need to know whether or not, this is a thickened wall or it's just a contracted gallbladder. Contracted gallbladders are adorable. They all look like this. I don't care if the patient recently ate. When I see a contracted gallbladder, it's reassuring to me that that patient actually has a pretty good ejection fraction of that gallbladder. It's functioning very well. If it was obstructed from a stone, it wouldn't, probably exude this very nice, this 3-layered wall structure. But remember that as opposed to the duodenum, this most outer layer here, that's all a very echogenic outer wall here that's very classic for the gallbladder. So we see that that inner layer that's sort of minimally reflective, and then that somewhat reflective inner layer. Here's some adorable contracted gallbladders. I just want to reach in there and just, bite them. They're so cute. Look at this one right here. This one's in the short axis here. Look at that little guy. You could miss it. You'd be like, I don't know. This is what is that, the duodenum? Nope, it's got that nice hyperechoic outer wall, so that's definitely contracted gallbladder. Eating Cheetos in my waiting room will cause this right here, this nice contracted gallbladder there. Tells me that it's functioning quite well. It looks like the duodenum. This is not a contracted gallbladder. That's actually the duodenum. It's got this hypoechoic outer wall. That's a contracted gallbladder. That's a duodenum. You see the similarity, though, right? I mean, you can see how you get confused between the two. But I just like to sort of point that out again. So when you worry about cholecystitis, acute cholecystitis, we think about there being a very thick outer wall here to our gallbladder, stones, shadowing. And if you actually were doing the ultrasound yourself, the patient, as you lean in with the ultrasound probe, the patient would say something like, yep, that's it right there. That's the pain that brought me to your ER. I love when they say that. So the sonographic Murphy sign is very, very specific for this being acute cholecystitis. Here's some pericholecystic fluid here. Such a rare finding. I hardly ever see this. I mean, it suggests there's been some microperforation going on. If you're going to see it, it's going to be probably posteriorly. Every time I think I see pericholecystic fluid, though, I go over to Morrison's pouch and it's like there's ascites there. I mean, and probably this case right here, to be honest with you, probably this was some ascites that happened to work its way over here next to the gallbladder. It's so rare to find actual legit pericholecystic fluid. But it's in all the textbooks, and if you see it, you know for sure the patient's definitely got a sick gallbladder. This may be a legit one, actually, because you see the nice thickened gallbladder wall here, and this anechoic fluid here is kind of wedging out like it would anytime fluid wedges out anywhere else in the abdomen there. You don't see it, and then boom, there it is, right up there adjacent to that gallbladder there, pericholecystic fluid. Here's another case of pericholecystic fluid. We see the stone, we see some shadowing here, thickened gallbladder wall, pericholecystic fluid. You lean in on that gallbladder and the patient lets you know this is acute cholecystitis. There's a study that we did, a small study looking at the gallbladder to try to determine if emergency physicians performing ultrasound of the gallbladder could be as accurate as the Department of Radiology was. And And we didn't use radiology though as the gold standard. We used pathology reports and patient callbacks as the gold standard, and compared our test characteristics to the test characteristics of radiology. And basically, it was a prospective convenience sample. We had all different performers doing this, residents, attendings, fellows, and we really were trying to define which patients had acute cholecystitis, not gallstones, acute cholecystitis. That was really the finding we were going for. And we did some callbacks a couple weeks later, and the patients that didn't go to the operating room had their gallbladders removed. So these are all the users, R1s, R2s, different residents and fellows and attendings at different levels. We had 189 patients scanned by 43 different emergency physicians. The majority went on to have ultrasound and radiology, and 26 had their gallbladders taken out. 23 had actual pathology-proven cholecystitis, and then we followed up as many as we could that went home. Our sensitivity and specificity is listed here. Our sensitivity was 87%, and the sensitivity for radiology was less than ours, 83%. And so this is just one of those things where at the time we did the study, leading up to, was having some drama with radiology, and when we were able to show them some of this data that, hey, look, you guys, we're kind of on par with each other here. Maybe we're a little bit better on the sensitivity. Maybe you guys are a little better on the specificity, but yeah, right here, here's their specificity, a little higher, 86 versus our 82. We're on, we're basically the same here. So let's knock off this business about the patient's not getting as quality of an ultrasound when 43 of my docs are doing this in my emergency department. So there's a little there's some limitations. There's a convenience sample, obviously. Whenever you're doing this, there's some confirmation bias going on. But that's how we do that. That's point of care ultrasound. You're putting the whole thing into a clinical context every time you're doing an ultrasound, and I think that's good. That's part of our using our clinical wherewithal as we're doing this. If we move on to the common bile duct here. It's the nice thing about the common bile duct. You hear about the Mickey Mouse sign discussed all the time. The Mickey Mouse sign, Mickey's right ear. That never made any sense to me. I really like to stretch the common bile duct out in a longitudinal plane, in a long axis on the screen. So I'll see that portal vein, that hyperechoic wall, that portal vein, and then I'll rotate the transducer to the patient's towards the patient's right. And as the probe sort of enters into this transverse orientation with the body axis, you'll start to see the portal vein, those hyperechoic walls, stretch out across the screen, and just anterior to that portal vein, you're going to see your common bile duct. So that's kind of how I do it. It runs very reliably with the portal vein. So this is the IVC down here. Here's the portal vein with its hyperechoic outer walls, and above it is the CBD. This CBD happens to be quite dilated. Whenever it reaches this common bile duct here, whenever it reaches the same or greater diameter than the portal vein, that's when I start, it catches my eye, I drop calipers, and I start wondering about some kind of choledocholithiasis going on, or other cause of biliary obstruction, like a tumor in the head of the pancreas. I start to get concerned about that. Biliary obstruction is never a good thing. Should always concern you to see a dilated CBD. So, but normally I don't drop calipers on normal ones. The majority are normal, right? I'm just looking for that portal vein. I stretch it out, and I see the smaller tube above it, and I stop. I don't stop and drop calipers on the normal ones. Only the ones that are positive. And you can throw some color on here if you want to have fun with it and see the different vessels here. I don't usually do that routinely. But if you look at this this case here, just the still image before I play the video, this is the IVC over here. The vena cava is coming along here. This is probably the aorta, not sure from a still. That's why we live in the video world in point of care. Here's that portal vein here with its hyperechoic walls, and this is the common bile duct over here. This is the duodenum over here, some fluid in it or something, contrast, I'm not sure. And this is the hepatic artery is looking at us here. So as the video goes, watch that portal vein, CBD. See how this CBD is of the same diameter almost as that portal vein, and that's what got my attention to stop, drop, and roll. No, to stop and drop some calipers on here. And I think this was like a 1.1, centimeter CBD. So what's a normal CBD? I forgot to mention that. 6 millimeters, up to 6 millimeters is normal. All CBDs for sure less than 6 millimeters is going to be normal. And then after about age 70, you get an extra millimeter per decade of life. So like a 70-year-old could have a 7 millimeter CBD, et cetera, et cetera. Patients who've had the gallbladders removed, they tend to have more enlarged common bile ducts, and so you got to put that into a clinical context as well. So again, if I was to just walk you through this anatomy on the still image, there's something wrong in this patient's liver. You see all these intrahepatic ductal dilatations going on, right? So that's the IVC. It's always the most sort of posterior thing on the screen. I see the hyperechoic walls of my portal vein, and then above it is my common bile duct, and all these little tributaries are all dilated out, intrahepatic ductal dilatation there on that patient. This is one of my top 5 favorite ultrasounds ever. This is an actual choledocholithiasis here, a stone sitting here in that distal common bile duct floating around here. Never seen that before or since. The portal vein is actually right here. It's just this is such an enormous, like a 2.5 centimeter CBD with all this intrahepatic ductal dilatation going on. Isn't that amazing? That is sick, literally and figuratively. This here is an issue. This is easy to miss. What are we looking at here? We're using our larger footprint transducer, and we just see it almost looks, when I first saw this image playing, video review in the QA room, wondering, is that a uterus? Am I looking at a uterus here with an IUD coming down here? We play, because there's nothing on the screen. You have no idea what's wrong with the patient. You have no clue where they are in the body. That's QA. But this is actually a gallbladder. This turns out this is a gallbladder right here, okay? And this is the liver over here. And this sludge can be very isoechoic with the liver parenchyma, and you could miss that sludge there somewhat easily if you're not careful. So just keep that in mind. And this is a stone somewhere. It's hard to project right there at the end of that clip. It's down towards the neck. And here's another thing we see sometimes. What do we see inside the gallbladder? We see these little pedunculated dingleberries hanging in there. What is that? There's little polyps in there. They're adorable. These little gallbladder polyps sort of hanging around there. Love them when I see those things. They're not causing any drama, What if you saw some comet tails coming out of those polyps? What's that when you see comet tails? I have a video of it, but I wouldn't play. It kept crashing my presentation. It was for the next slide. If you see comet tails that come out of a polyp in the gallbladder, but the comet tails don't go all the way to the bottom of the screen, it's just a little reverb coming down, maybe for a couple of centimeters. What's that? What is that called when you've got some reverb coming out of the wall of the gallbladder for a couple centimeters? That's adenomyomatosis. It's got absolutely no meaning whatsoever. It's just pure gallbladder trivia, but we see it on ultrasound sometimes, and if you want to sound really smart, you say adenomyomatosis. It looks just like a polyp, but there's like these little comet tails coming down. I'm sorry that video wouldn't play. I was messing with it earlier. So again, sludge looks just like the liver. You could easily mistake this as just like a tumor or something in the liver there. In fact, I had a Dr. Shane Arishinkoff from Vancouver, University of British Columbia, came out. He's an intern. So he spent a year with me. We had a wonderful year together. Right in the beginning of his year, so he used the word query. I didn't really know what he meant by that term, query. That means question, is this a liver mass? And so that's like a Canadian thing. And so I'm looking here, and I'm like, yeah, this looks like a mass here in the liver. What the heck is that, Shane? And he said, Shane was here last year, I think, at Castlefest. He said, yeah, he goes, I don't know what that, we thought this was a liver mass. Patient had a CT scan. This is just a gallbladder filled with sludge. See that? See how it looks? It can kind of catch you off guard a little bit. So just keep that in mind. That's sludge. Here's another patient here. We're wondering, what are we looking at here? Is this a gallstone in the gallbladder? Nope. What is this? That's just the duodenum, sort of peristalsing along here. Look for peristalsis, roll them on the side. Try to get that duodenum to fall out of the place there. Could somebody hand me my drink right there? I'm super parched. Thanks. All right, no rum in that Coke. All right. Look at all this sludge here. Another sludgy gallbladder. I'd just like to point these out. And this patient's got a dilated CBD as well. You see that there? There's your portal vein, dilated CBD. Big giant thumbprint of a CBD. So just to kind of summarize the gallbladder, I think have the patient take a deep breath, roll them left lateral decubitus, get that duodenum slide out of the way, use a small footprint transducer, go X -7. If you're having some troubles there, seeing with your larger footprint probe. Air in the duodenum can look like gallstones. Think a wall echo shadows going on if you can't find the gallbladder. And then for the CBD, you want to look anterior to that portal vein.
I said this at Castlefest, and I'll say it again. I've been teaching ultrasound for a long time, but when I listen to Chris Fox talk, I realize how many of the common things I say or the things I've heard other speakers say that actually started with Chris. This guy's permeated his knowledge into almost every school of point-of-care ultrasound in the country, and it's no wonder once you've seen him talk. If you want to catch Chris live next year at Castlefest, head on over to castlefest2017.com and join the club.
Oh man, this is really living.
We're committed to the art and nothing stop us, not even a train, plane, tractor, all of us as we feel the rhythm inside the marrow of our bones, and we're fascinated by the music sounds and headphones.
Free box beats brings me a relevant speech. Like two girls were matching, going to a fashion pageant, asking for some passionate actions with any old masculine man friend. Wait a minute, let me change my tangent. Flows tactical, inapplicable for PCs and apples. I snap to slap you. They're cool, natural, quite attached to getting rich and getting some chicks, and maybe a fan that's willing to chill in the sticks. I'll tell you what I think, even if society isn't behind me or the community isn't in unison. Open your ears and your mind to our tones, cause it's a free box bringing you pleasure to your headphones.
If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
Yeah, we can definitely do that, or we could be better clinicians and use our ultrasound.